Now, before we proceed on to the other topics, there is one special topic that needs to be discussed over here, which is a kind of a adaptation that the body has. And this is known as autophagy. Again, like we have done for most of the topics, we are going to split the term and understand the meaning. Auto means self. So, auto over here means self. And phagy means eating. So this is nothing but self-eating. This is nothing but self-eating. Now what is happening? The cell starts eating its own contents. The cell has started to eat its own contents. I can safely say that this is also known as cell cannibalism. Again, a question that has been asked. Cell cannibalism is nothing but autophagy, self-eating. Now what we need to know, when does such a situation arise in the body that the cell starts eating its own self? What are the conditions in which we will see autophagy? So first of all, this is seen in extreme malnutrition. When the body is deprived of all the nutrients, how will the cell survive? Cell will start eating its own contents. So the first scenario will be extreme malnutrition. Second, this is also seen in old age or senile. In old age also, when the body does not get adequate nutrients, then the body tries to adapt by eating its own contents. That is a survival adaptation that the body is trying to do. Apart from this, the same mechanism is also seen in cancers. Autophagy is also seen in Alzheimer's disease. It is also seen in Alzheimer's disease. And lastly, it is also seen in Huntington disease. It is also seen in Huntington's disease. So these are the list that you need to know. But what you need to know further is that A for Alzheimer's, A for acceleration. In Alzheimer's disease, autophagy is accelerated. There will be more of autophagy. Whereas in Huntington, there is inhibition of autophagy. So A for Alzheimer's, A for acceleration. Huntington disease has H, inhibition has H. So inhibition of autophagy will be seen in Huntington's disease. Now students, since this is a very recent concept, the examiners for the recent concepts tend to also ask you questions on the scientist. So before we go on to the actual mechanism, we must understand the historical aspect. So there was a scientist named Y. Osumi who in 2016 received a Nobel Prize for this. He also received a Nobel Prize for this. Students, please note that such questions where scientists are involved are very favorites with the AIIMS examiners. Y. Osumi in 2016 discovered this and also received a Nobel Prize for autophagy. And he told us that what is the gene that is responsible for autophagy? The gene that is responsible for autophagy is ATGS1. Autophagy, just those letters, ATGS1. That is the gene that is responsible for autophagy. Now, just that we are talking about autophagy genes, there has to be some collateral information that we'll try to add on to this. So, on the similar lines, talking about this gene, there is also something known as ATGS5. There is also something known as ATGS5. Now, students, remember, those individuals who have ATGS5 gene mutation. If someone has ATGS5 gene mutation, that person is more susceptible to which infection? More susceptible to tuberculosis. Very important high yield question that we have expected in the recent exams, because autophagy is a newer concept. What is the gene for autophagy? ATGS1. Which gene mutation can result in increased susceptibility to tuberculosis? It is ATGS5. Now coming back to the actual topic, that is autophagy. We've discussed the meaning, we've discussed the conditions, we've discussed the scientist and the gene. Now we are left with the mechanism. How is autophagy taking place? Now students, for this, first of all, this was the scientist that you need to know. So this particular concept or this particular mechanism was given to us by Y. Osumi, who discovered this and received a Nobel Prize in 2016. So whatever mechanism of autophagy we will talk about was given by this particular scientist. What are the mechanisms that you need to know? So this is the mechanism, students, that is important. Autophagy means self-eating. Very simple. This will happen whenever there is some kind of nutrient depletion. Nutrients go down, like we just discussed, in malnutrition, old age. Nutrients go down, the body starts eating its own contents. How? The first thing that the body will do, if these were the organelles, like the mitochondria, endoplasmic reticulum, the body first forms a membrane around them. It will try to entrap whatever it has to eat. If it has to eat the mitochondria, it will make a layer around the mitochondria. If it has to eat the endoplasmic reticulum, it will make a layer around the endoplasmic reticulum. So it first formed a layer around whatever organelles it had to eat, and that layer is known as autophagic vacuole. That layer is known as the autophagic vacuole. Next, once an autophagic vacuole is formed, what will it fuse it? It will go and fuse with a lysosome. So we can say, first we had an autophagosome. That is now going to fuse with a lysosome, resulting in the formation of autophagolysosome. Just combine all the terms. Autosome means auto self eating up the own contents. When it combines with lysosome, autophagolysosome. Finally, the lysosome is going to release all its enzymes and is going to eat up all the contents in this particular step. So finally, the endoplasmic reticulum, the mitochondria, whatever the body was trying to eat has been eaten up by which enzymes? Enzymes released from the lysosome. Why is it eating it up? Because whatever mitochondria, rough endoplasmic reticulum, ribosomes, whatever it eats up, it is deriving nutrients. Remember, this is happening because there was nutrient depletion. So by eating this, the body is making up for its nutrients. So this is a kind of a survival mechanism that the body has. So this is a very important concept, a recent concept that you need to know, that is on autophagy. Now we have discussed the main mechanisms of reversible and irreversible cell injury. What we are going to start with next is a more basic concept, but one or two questions can definitely be expected in the exam from this. Right in the beginning, I told you that whenever a cell undergoes any injurious agent, is inflicted upon by an injurious agent, what does the cell try to do? What does the body try to do? The body will try to adapt. Now, this is what we are going to read. This is known as cellular adaptation. This is known as cellular adaptation. And under cellular adaptation, the first one that we will discuss will be hypertrophy. This hypertrophy, simultaneously, we will correlate with another adaptive mechanism, that is hyperplasia. Now, first and foremost, what is the basic difference in the definition of these? What is hypertrophy? It is an increase in the size of a cell, size or an organ, of the size of the cell or the organ. Hyperplasia, plasia means growth. So this is an increase in the number of the cells. This is the most basic difference that you can have between hypertrophy, hyperplasia. Hyper in both means increase, but trophy would mean the size of the cell or the organ. Plasia would mean the number of the cells will increase. Hypertrophy happens because of certain transcription factors. This increase in size is due to certain transcription factor increase. There is one name that you need to remember, that is GATA4. This is a recent transcription factor discovered. Why is hypertrophy happening? Why is the cell size increasing? Because of an increase in transcription factor, example GATA4. Now examiners, rather than putting up straight one-line questions, tend to twist the questions in the form of histories and will try to give you examples. So you need to actually know the examples in both of these. First, what we will do, we are going to first do those examples which are common to both of these. Example, let's see the first one. When we are talking about a pregnant uterus, or you can say gravid uterus, uterus in pregnancy, it will show both hypertrophy as well as hyperplasia. It is a common example, but the examiners would definitely like to trick you somewhere down the line. So if they give hypertrophy and hyperplasia as separate options, what will you select? Remember, it is more of hypertrophy than hyperplasia. So if you have to select any one, it will be hypertrophy. But if you have the option of both, then that is the best answer that you can provide. Next, let's look at a similar common example. Let's consider breast development. Breast development, please note, during two stages. First, puberty. Second, pregnancy. Breast development during puberty and pregnancy again can show both hypertrophy as well as hyperplasia. Again, if the examiner tries to trick you and gives these as two separate options, what will you select? Remember, breast development during P for puberty, P for pregnancy will show P for plasia, that is hyperplasia. So if you have to select any one, in this scenario, it will be more of hyperplasia. So these are two important questions we did, gravid uterus and breast. These are common examples. If you have to select any one, for gravid uterus, hypertrophy. For breast development in P for pregnancy, P for puberty, it will be P for plasia, that is hyperplasia. Now that we've done the common examples, let's go on to a list of the individual examples that these adaptive mechanisms carry. Hypertrophy examples that you need to know. Okay, examples of hypertrophy. Now continuing with what we studied, breast development we did during puberty, we did during pregnancy. One important event is left, breast development during lactation. So remember, breast in lactation or a lactating breast shows only hypertrophy. That is why I told you to remember the P's. P for puberty, P for pregnancy, P for plasia. But lactation will show hypertrophy. Other than this, the next example that you need to know is in bodybuilders. Now in bodybuilders, many of us do hit the gym once in a while. So bodybuilders have an increase in the skeletal muscle mass. This increase is actually hypertrophy. The increase in the size of the muscles is taking place. Muscle is a non-dividing cell, so it cannot divide and produce hyperplasia, increase in number. It cannot do that, but it can increase the size. It can increase in its size, so it can undergo hypertrophy. The third example that we have is obstruction. Now this is one of those examples that tends to come up as clinical histories. Obstruction. How will we understand this? For example, if this is an intestine, just a segment of the intestine, or for example, this is the urinary bladder, and in both of these there is a growth present. Say there is a growth here and there is a growth here. Either ways, in both of these, what is happening? Will the food be able to pass through the lumen? No, because there is an obstruction. Will the urine be able to pass through this urinary bladder? Again, no, because there is obstruction. So where is all the food and all the urine accumulating? Proximal to the obstruction. Just above this we are going to have a lot of food particle. Above this we are going to have all the urine. So how will the body adapt? There is an obstruction beyond which all the food is accumulating. The body has to accommodate that, so there will be hypertrophy. So remember that proximal to an obstruction, there will be hypertrophy. Any obstruction example given, these are just two random examples that we've taken up. Any example of an obstruction given in the question, proximal to the obstruction, the organ will adapt by hypertrophy. The last example that we need to know in this particular category, that is example number 4. Now we know that the heart, from the left ventricle, the heart is pumped into the aorta. This means that if the heart has to pump blood from the left ventricle into the aorta, the left ventricle should have a higher pressure. That is why it will pump blood into the aorta. What if a person is suffering from hypertension? In hypertension, the pressure in the aorta is also very high because the patient has hypertension. So now the left ventricle will have to pump blood with more pressure. Because it is doing this with more pressure over a period of time, it will result in left ventricular hypertrophy. Again, adaptive mechanism. Why? Aorta has more pressure. To pump blood into this, the left ventricle has to increase its pressure further. Over a period of time, lands up in hypertrophy. So these are the most important examples of hypertrophy that we need to consider. The next set of examples that we will be dealing with will be of hyperplasia. Now hyperplasia, one very important concept is hormone. We are going to deal with the response of hormone in two particular organs. One, that is the endometrium, and the other is going to be prostate. Endometrium and prostate. Now let's first deal with endometrium. In endometrium, what is the hormone that is responsible for the growth of the endometrium? It is responsive to estrogen. So if there is any condition in which the estrogen increases, what will happen to the endometrium? There will be endometrial hyperplasia. There will be endometrial hyperplasia. So hormone acting on the organ will respond by increase in the number of the cells, hyperplasia. Why is this important to know? Because endometrial hyperplasia, if not corrected, if not treated, can progress to endometrial cancer. That is why it is important. Any hyperestrogenic state in the female body, more of estrogen, more of hyperplasia, not treated, will result in cancer. That is why it is important to know. The other organ that was responsive to hormone was in males, that is prostate. Now just like estrogen was responsible for hyperplasia in endometrium, what is responsible for hyperplasia in prostate? Many students answer this as testosterone. Now I want to tell you that this is not correct. It is not testosterone which causes prostatic hyperplasia. Testosterone is converted into dihydrotestosterone. Dihydrotestosterone by an enzyme called 5-alpha reductase type 2. 5-alpha reductase type 2. So testosterone by 5-alpha reductase type 2 is converted into dihydrotestosterone, and finally this is the component, or this is the compound which is going to result in prostate hyperplasia. Prostate hyperplasia, which we commonly know or denote as BPH. Benign prostatic hyperplasia. So the question that you need to know, what is responsible for hyperplasia? Is it testosterone? No, it is one step ahead of testosterone, that is dihydrotestosterone. Very important question of surgery and medicine. How do you treat a patient of benign prostatic hyperplasia? We know that the causative agent here is DHT. So stop the synthesis of DHT. How do I stop the synthesis of DHT? By giving a 5-alpha reductase type 2 inhibitor. And what is the drug which inhibits this? That is finasteride. So finasteride will inhibit 5-alpha reductase type 2. DHT is not formed. Hyperplasia will not occur. Now one last question over here that you need to know, friends. Like we had discussed, endometrial hyperplasia not treated will result in endometrial cancer. BPH not treated, will it result in cancer? Very important question, not only for your theoretical aspect but also something that will be commonly asked in daily practice. So remember, this does not lead to cancer. Endometrial hyperplasia can cause cancer. Prostatic hyperplasia will not result in cancer. This is a very important question that you need to know. So these were the first two mechanisms by which a cell can adapt: hypertrophy and hyperplasia. Hypertrophy was increase in cell size. Hyperplasia is an increase in cell number. The third adaptive mechanism that we will begin with is atrophy. Now, just like we discussed right now, atrophy is a decrease in both the size as well as the number of the cell. So it is just a complete reversal of both hypertrophy and hyperplasia. So it is a decrease in the size and it is a decrease in the number of the cells. Now what we need to know, why and how is the size and number of the cell decreasing? So what is the mechanism of atrophy? Remember, there is one pathway that is present known as the ubiquitin proteasome pathway. The ubiquitin proteasome pathway. This pathway is primarily responsible for the decrease in the size and the number of the cell, that is atrophy. Now what we need to know further, what all conditions in the body can result in atrophy, or indirectly we can say what are the examples. Simple examples that we have over here. First, disuse atrophy. Disuse atrophy. Now students, just focus on the term disuse. For example, a person suffers from a fracture. Now in a fracture, there is a cast that is applied so that the bone pieces are held together and they heal properly. But students, in this process, what is not moving at all during the duration of that cast is the muscle. For example, there is a fracture of the hand. The bone will heal because of the cast, but the muscles are not moving, the hand muscles are not moving. So the person will land up with disuse atrophy of the muscle. That is why following fracture healing, physiotherapy and exercises are advised so that all the strength that the muscle has lost can be regained. The second example is something known as ischemic atrophy. Now students, this is again from the name itself. If we cut off the blood supply of an organ, of a tissue, will it be able to grow? No. The blood supply becomes slow, becomes less, is cut off. The organ is going to undergo atrophy, ischemic atrophy. Similarly, if I cut off the nerve supply, so we are going to call it denervation atrophy. If I cut the nerve supply of an organ, again the size and the number of the cells will decrease. The fourth example is again a common one, malnutrition. Now when the nutrients to a cell decrease, then automatically the size and the cell number is going to reduce. There is going to be atrophy. Fifth, this can also happen because of endocrine causes. Example, hormones. Now if the hormonal supply to an organ is cut off, it is going to undergo atrophy. Best example, we just discussed endometrium is functioning under the response of which hormone? Correct, estrogen. Estrogen. So estrogen is going to be responsible for the growth of the endometrium. But if estrogen withdrawal happens, if there is estrogen withdrawal, what will happen to the endometrium? There will be endometrial atrophy. A very important point, because endometrial atrophy can result later on in endometrial cancer. So students, now just try to recall, if endometrial hyperplasia is left untreated, that can also result in cancer. Endometrial atrophy can also result in cancer. So indirectly, I can say that if we have a patient of endometrial cancer, this can be following endometrial hyperplasia. Such an endometrial cancer is known as a type 1 endometrial cancer. Other scenario, this endometrial cancer can occur following endometrial atrophy. This endometrial cancer is now known as type 2 endometrial cancer. Why is it important to know? Because this type 2 endometrial cancer, which is occurring following endometrial atrophy, is going to have a worse prognosis. For the patient, prognostically, it is going to be bad. It is going to have a worse prognosis. It is seen in old age and it is associated with p53 mutations. So again, going slightly into female genital pathology, but very important because the concept building happens in this chapter. Both hyperplasia and atrophy of the endometrium can result in endometrial cancer, respectively type 1, type 2. Which is bad for the patient, worse for the patient? It is type 2. So this was the third adaptive mechanism that we had, that is atrophy. Now we start with the fourth adaptive mechanism. The fourth adaptive mechanism, and this is something known as metaplasia. This is known as metaplasia. Now metaplasia means a change. So there is going to be a change of either one epithelium into another. So any one epithelium will change into another epithelium, or this change can be between mesenchymal tissues. So any one mesenchymal tissue will change into another mesenchymal tissue. So metaplasia is nothing but a change. One epithelium changing into another, one mesenchymal tissue changing into another. Now what we need to know over here, why is metaplasia happening? What is the mechanism? Again, a direct repeat question that you need to know. Every cell and organ in our body ultimately comes from which cell? Correct. It is the stem cell. So every stem cell knows that ultimately it has to form which tissue, ultimately it has to form which organ. But if the stem cell undergoes reprogramming, in that scenario, instead of forming one epithelium, it will form another epithelium. Instead of forming one mesenchymal tissue, it will form some other mesenchymal tissue. So that reprogramming of stem cells is mainly responsible for metaplasia. Two important points about metaplasia you need to know. Metaplasia is actually a protective phenomena. It is a protective phenomena. Second, it is most important point. It is a reversible phenomena. Students, please note this particular point of metaplasia catches the maximum questions. It is a reversible phenomena. Whatever stimulus was causing this change, if we remove that stimulus, the entire change will get reversed. It is reversible. Most important point about metaplasia. Now metaplasia, we've done a lot of theoretical aspect. Let's now try to understand the same with the help of few examples. So let's take up the first example. As I said, either one epithelium will change into another or one mesenchymal tissue will change into another. So that is exactly how we are going to deal with it. For example, when epithelium is changing, so I will call it epithelial metaplasia. We will call it epithelial metaplasia. So let's take the first example under epithelial metaplasia, that is when columnar epithelium changes into squamous epithelium. When columnar epithelium changes into squamous epithelium. Where is this seen? For example, everyone knows that the lining of the lung is going to be ciliated columnar epithelium. So the lung is going to have ciliated columnar epithelium. But in a patient who is a person who is a chronic smoker, or if someone has vitamin A deficiency, in that scenario, this stimulus will cause reprogramming of the stem cells, and this columnar epithelium will then convert into squamous epithelium. Now, how will you use the terminology? When columnar is changing to squamous, we will call such a scenario, this will be known as squamous metaplasia. Squamous metaplasia. So the terminology is basically what is finally formed. When columnar changes to squamous, I will call it squamous metaplasia. Other way around, if squamous would have changed to columnar, I would have called it columnar metaplasia. So whatever is formed in the end, that is the terminology that I will use. Remember, it is squamous metaplasia which is the most common. Out of all the conversions and the possibilities that we have, squamous metaplasia happens to be the most common. Let's take another example, complete reversal. After columnar to squamous, now let's take an example of squamous epithelium converting into columnar epithelium. A very important mechanism that we have, especially when we will deal with GI pathology, and that is in the esophagus. Squamous epithelium is present in the esophagus. In a person of gastroesophageal reflux disease, a person of GERD, when the acid reflux happens, the squamous epithelium of the esophagus is then converted into intestinal columnar epithelium. So please note, it is just not columnar. Which type of columnar? Intestinal columnar. This word is the most important in this particular pathway. Intestinal columnar epithelium. How will you identify intestinal columnar epithelium? Because it will have presence of something known as goblet cells. We identify intestinal columnar epithelium by the presence of goblet cells. Goblet cells contain what? They contain mucin. The question that comes now, is there any special stain that can be used for staining this mucin or staining this goblet cell in this particular condition? That is known as Alcian blue. Same things we will also discuss again when we do GI pathology. This particular condition, what was happening? The normal squamous epithelium of the esophagus is converting into the intestinal columnar epithelium. That can be stained for goblet cells by mucin. This is known as the Barrett's esophagus. So Barrett's esophagus is conversion of squamous to intestinal columnar. If someone asks you what is the hallmark of Barrett's esophagus, remember this epithelium. This particular epithelium over here, this remains the hallmark of Barrett's esophagus. Hallmark of Barrett's is intestinal columnar epithelium. Why are we dealing with this particular example in so much of depth? Because remember that Barrett's esophagus is going to be a cancerous condition. If we do not treat this, it will result in carcinoma. What was the agent causing Barrett's esophagus? The agent was gastroesophageal reflux disease. If I don't treat this gastroesophageal reflux disease, this patient of Barrett's esophagus will ultimately land up in cancer. That is why it is extremely important. So we were discussing epithelial metaplasia, most common being columnar going into squamous, like in the lung in smokers. Other way around, squamous going into intestinal columnar in Barrett's esophagus. There is another category in which it is commonly known as mesenchymal. It is commonly known as mesenchymal metaplasia. What do we mean by this? One mesenchymal tissue, for example, muscle, is converting into bone. What would you call it? Myo for muscle, myositis, and for bone, this will be ossificans. Myositis ossificans. So myo for muscle, ossificans for bone. So you will always remember myositis ossificans is muscle changing to bone. Why? Whenever there is any trauma. So because of trauma, wherever, for example, trauma to the lower limb, muscle is present. Following trauma, there is reprogramming of the stem cells, and the muscle now, while healing, there is formation of bone. Myositis ossificans. So the key points about metaplasia ultimately remain that this is first reversible, and second, it is because of reprogramming of the stem cells. So these were the four main adaptive conditions that you had to know. Out of all these four, there is one of these that also catches an image-based question, which is very important. And that image-based question that is usually put up by the examiners is this. Which type of adaptive mechanism can you see over here? Can everyone appreciate that this particular image has two distinct parts? This epithelium looks different and this epithelium looks different. And by me saying two different epithelium, you can now easily catch that we are talking about something known as metaplasia. So students, this is actually squamous epithelium. This is squamous epithelium. And what we have on this side, all these glands, this is the intestinal columnar epithelium. This is the intestinal columnar epithelium. What you can appreciate over here, these round structures, these are the mucin-filled goblet cells. These happen to be the goblet cells. So we have squamous epithelium that is converting into intestinal columnar epithelium having mucin-filled goblet cells. This is a classical case of Barrett's esophagus. So out of all the adaptive mechanisms, remember students that Barrett's esophagus is one of those adaptive mechanisms which can fetch you an image-based question. So these were all the four adaptive mechanisms that we had, that is hypertrophy, hyperplasia, atrophy and metaplasia. Now we are starting with a very important topic in this chapter, which is a recent advance and is now one of the current favorites with the current board of examiners. That is cellular aging. Not only is it very interesting, but also a lot of research is happening on this particular topic. Things which are under research automatically tend to fetch a lot of questions in the NEET PG exams. So we are starting with cellular aging. The first thing that comes in everyone's mind, why are we aging? Why are humans aging? Why is the cell aging? So remember, there are multiple theories that have been given for this. There are multiple theories that have been given. Now what are those theories? Let's deal with them one at a time. The first theory says that cellular aging is because of free radicals. So free radical injury is the first mechanism that they have set for cellular aging. Free radicals are going to injure the cells by their oxidative properties. Maybe our antioxidants that we had read are not able to protect us. The person lands up with aging. Second, this is also happening because of cross-linking of collagen. This is also happening due to the cross-linking of collagen. Third, another theory says that this is due to DNA damage. Throughout the lifetime, there is a lot of damage that happens to the DNA. That DNA damage is responsible for cellular aging. Another theory says that because of a decrease in insulin growth factor or due to insulin resistance, there is cellular aging. So there are many more theories, but out of all of these tend to be the most important theories, with addition of one that we will have to do in slight more detail, the fifth theory. That is the theory of telomere shortening. That is the theory of telomere shortening. Now, what is this theory of telomere shortening? For example, if this is a chromosome, the ends of the chromosome have something known as telomeres. End of every chromosome has multiple repeats of a telomere. Now, what are those repeats? The sequence is TTA triple G. That is the sequence of a telomere that is present. Multiple of such repeats are present at the ends of chromosomes. Now what we need to know is, with every cell division, for example, if there were 5 telomeres, and the cell underwent division, after that only 4 telomeres will be left. After another cell division, only 3 telomeres will be left, and so on. So with every cell division, the number of these telomeres will decrease. Ultimately comes a point when there are no telomeres left. There are no telomeres left. That is when we have progressed towards aging. That is when we have progressed towards aging. So, telomere shortening results in aging. Is there anything that can prevent this shortening? Is there anything that can prevent this telomere shortening? Yes, there is an enzyme known as telomerase. There is an enzyme known as telomerase which can prevent this telomere shortening. It prevents telomere shortening. Now, what would be the cells in which telomerase activity will be very high? Yes, it is obvious that this activity is very high in the germ cells, and it is extremely low, or you can say even absent, in the somatic cells. The germ cells have to multiply more, their telomerase activity is very high. The somatic cells do not multiply, their telomerase activity is very low. What forms the basis of this is that telomerase activity is corresponding to telomere shortening. More the telomerase activity, telomeres will not shorten. Telomeres will not shorten, aging will not occur. Indirectly, it would be safe to say that telomerase is the immortality gene. That is how they've labeled it. It is the immortality gene. That is, if someone has very high levels of telomerase, in that scenario, the telomere shortening will not occur. If the telomere shortening does not occur, aging can be prevented. Now we have done a number of theories. There is one phenomena over here. I just told you that with every cell division, the telomeres are going to shorten. So how many cell division on an average? So that brings us to something known as the Hay-Flick limit. That is known as the Hay-Flick limit, or you can say the Hay-Flick phenomenon. What does that say? that before the telomeres finally finish, on an average, every cell undergoes a division approximately 60 to 70 times. Approximately 60 to 70 times on an average, every cell undergoes a division before which the telomere shortening will happen and cell will age. What is this known as? This is known as the Hayflick limit or the phenomena. Now going back to our discussion, we had discussed these 5 theories for cellular aging. Now if a question comes up, which out of these 5 is the most accepted? Remember the first one. The free radical injury is said to be the most accepted theory for cellular aging. This is the most accepted theory. Again, a very important question that we have. Now, why was I saying in the beginning that this is a topic of research? That is because now the scientists are trying to figure out ways by which we can prolong survival. So how can we prevent, I can say prevent aging. One way is prevent aging, or indirectly they want to prolong survival. And for this they are saying that they've come up with certain proteins. If you want to increase the lifespan of a person, if you want to increase the age of a person, they are saying that there are certain proteins that are present known as sirtuins. Now sirtuins are certain proteins. Every protein will be under the effect of a certain gene. So which gene is controlling sirtuins? Just the first 4 letters, the SIRT gene. SIRT, SIRT, gene, full form, protein will be sirtuins. Now, if I want to prolong the survival, how can I increase sirtuin levels in someone's body? So remember, sirtuins will increase under 2 scenarios. As per the current research, sirtuins will increase under 2 scenarios. First is when the person has calorie deficit. So, in order to increase sirtuins, calorie deficit is mandatory. So, not a good news for many. You need to restrict the calorie intake. Calorie deficit will only result in increase in sirtuins. Second, another research and a very widely accepted research now says that with the consumption of wine, there is increase in the sirtuins. So sirtuins can, as per the research, now increase by 2 ways. Either first, the calorie intake is reduced, and secondly, by wine consumption. Now this will increase sirtuins. So now the sirtuins in a person's body have increased. How will they increase the age of the person? They will increase the age by improving the insulin tolerance. Just now we had studied one theory of cellular aging was insulin resistance. So they are going to improve the glucose tolerance. And by improving the glucose tolerance, they are going to prolong the age of a person. Now first it was said that sirtuins only have a role in aging. But now it is said that they also have a role in cancers and they also have a role in diabetes mellitus. So this is a question that has been asked in the previous years. Sirtuins have a role in A, aging, B, cancers, C, diabetes, or D, all of the above. So remember, sirtuins have a role in all of these. A for aging, C for cancers, and D for diabetes. So we'll remember it by ABCD. A for aging, C for cancers, and D for diabetes mellitus. So it is going to have a role in all of these particular things. Now the last concept about cellular aging, till now we have been discussing how can we prolong survival, how can we prevent aging. One thing that we need to know, is there any disorder that we need to know for premature aging, in which the person tends to age earlier? Yes, this is one of the favorite movies of many of us, in which we had come across progeria. Similar to progeria, there is another disease known as the Werner syndrome. This is the Werner syndrome. Remember, in Werner syndrome, there is a defect. There is a defect in the enzyme DNA helicase. Because of a defect in the enzyme DNA helicase, the person tends to mature or tends to age faster. So probably by the age of 8 or 10, the person has already attained what a regular individual would attain at the age of 70 or 75. So this is premature aging. The name of the syndrome is Werner syndrome. Now there is one very common source of confusion that most students have. There is something also known as a Werner syndrome. Please remember, Werner syndrome, the one that has the M, that is not premature aging. That basically M, so that stands for Men 1 syndrome. The other name for Men 1 syndrome is Werner syndrome. What we are dealing with right now is Werner syndrome, and Werner syndrome is the one that is premature aging. So these are the important points that you need to know for cellular aging.